Okay, so dear colleagues, now we start with the live case with Nicola Palena, and they will show the presentation. They will introduce the team and the case, and then we'll go for the lectures. Okay, so could you show us the case? Could you present us the case? Do you hear us? Yeah, you are working very hardly. Thanks.
Hello?
Hello?
Hello, can you hear me?
Yes? Can you hear us?
Yes. Can you introduce the patient? Because...
Yes, we're here with Dr. Mariano Palena. My name is Mariano. We're live streaming from the National Heart Hospital in Sofia. So the case is coming to the presentation. Yes, we have a 73-year-old male, Rutherford 5, small wound. The lateral malleolus. ABI 0.5. He has arterial hypertension, diabetes mellitus, and he is an ex-smoker. There is one previous attempt to open the popliteal artery, unsuccessful. Can we put the някой трябва да сменя това. Can we put the angio? Предишните ангия.
Да, вижда се. Вижда се ангиото на техния екран.
Предишното ангио. Да.
Това вече...
Could you present the previous angio? Now we see that you are burning.
Mariano.
Yeah, so guys, here we are. We did a 6 French antegrade access and the ultrasound in the proximal SFA for a high femoral bifurcation. I don't know if you can see the images or not.
Трябва да пускаме първите. Добре. Давайте.
Can you see the images? We are going to show you.
We just see one stencil image, but if you can show
second,
the first angio before the intervention or previous one.
Okay, that's it. So 6 French antegrade sheaths in the proximal SFA, good SFA, occluded and fully dissected popliteal artery. You can see the dissection. Go. With occluded bifurcation, no ostium of anterior, no TP trunk, but peroneal, posterior, and good flow through the dorsal circulation for the foot. So we engaged the occlusion with Oscar 6 French 5 millimeter catheter device. We were unable to avoid the previous dissection. So we finished in the same dissection. We went till the ostium of the anterior, and we failed the re-enter clearly. So we did a retrograde access in the distal medium part of anterior. We went luminally going up, go please, till the pop, and when we went in P3, we finish again out. So clearly showing us that the popliteal artery was dissected and perforated. And as you can see now, we are fighting between the antegrade and the retrograde to try to see if we can gain the lumen of the anterior tibial. Why fighting? Because we have the retrograde access in the lumen, we have the antegrade wire advancing subintimally, and we are completely and continuously failing to meet the wires. We are not able to engage the lumen of the anterior tibial. So we are managing to do a cart and reverse cart strategy to try to see if we can re-enter somewhere else. But unfortunately, the amount of calcium as well as the previous dissection and perforation, are not giving us an easy life case. Anyways, Still, we have some other ideas, but we would like to hear from you, from the panel, suggestions,
what is your
impressions,
plan
and
now?
so on.
So congratulations, you punctured distally the anterior tibial artery, and now you are trying to the re-entry. So we'll go for one presentation, but meanwhile we ask some questions. What is your plan now? Do you want to do a rendezvous technique, or do you want to use a special re-entry device, or what I would do now, I would do HD ADR with IVUS guidance, because that is
Look,
very
you
fast.
were
But
so,
now you
so
passed.
much of help.
You passed now.
Because
so
the
you are
time
good.
you suggest a lot of things, the wire decide to go, and probably in the lumen.
You are in the lumen.
So
No, congratulations.
please, guys, continues
Okay.
suggesting and speaking, because you were a lot of help. Yeah, the guide wire is navigating now, so we are going to remove this. We are going to pre-dilate a bit. This balloon is a bit big, probably.
Okay.
So we
We
are
will
going to
start
pass
with
the
the season
2.5
two.
balloon
Peripheral
to
artery and
fix
venous
this
intervention.
retrograde access and to manage the distal dilatation of the
the audio?
tibial that was fully diseased. And at the end, probably we will finish with the stent in this popliteal artery, because probably we will have.
Thank you very much.
We will
connect
have a lot of dissection.
after
Remove
the
retrograde. We are going to do the most
the lecture of Zlatan.
Yeah.
Invasive pressure guidance for lower limb intervention. Our colleague from Hungary.
Нищо не се чува в залата.
As we said in Italian.
Professor Nikolov, we would like to continue with the program, and we'll come back in some minutes to see the results, if it's possible, okay?
Yeah. When you want, we are here to discuss with you.
Okay, thank you very much.
Thank you. Che culo, eh?
So we'll go back to the live case now. Dr. Palena and St. Nikolov are waiting for us. Okay, here.
Okay, can you go back to the images? So we left in the precise time in which we were able to engage the lumen. So with the advantage Traco 14 guide wire, we pass in the lumen of the anterior tibial. We did a 3 millimeters balloon dilatation, as you can see in the monitor, to fix the retrograde axis. And in the meanwhile, we were able to go around till the foot and around the arch in the lateral plantar artery with the same 014 guide wire. Afterwards, we did a 2.5 dilatation with a very long balloon, 2.5 to Henry Paseo 014 balloon. We dilated the dorsalis pedis, all the anterior tibial, and even partially the lateral plantar, as you can see. After this, we did a check. You can show the video running. This was the distal check. You can see good lumen of the anterior tibial, heavily calcified artery, but good lumen in the arch, good lumen in the dorsalis pedis, with good flow, reverse flow in the lateral plantar. Proximal check of the anterior tibial, still some dissections, residual stenosis in the ostium. So we decide to go with the 5 millimeter, 2 minutes. This was the result, excellent result from my perspective in the proximal anterior tibial. Good at P3, still small P1 and P2. So we decided to go with a 6 millimeter balloon. We did 2 inflations at 6 millimeters, and we right now complete the 2 minutes dilatation in P1, P2. So we are going to remove this 6 millimeter balloon to show you the result and to try to discuss, if you have 5 minutes for us, try to discuss all together about the final treatment. Till now, what we did was to cross, to re-enter, and to dilate, with the objective to have acceptable vessel preparation. But we were, with Nadalin for sure, we were discussing about the final treatment, but we would like to discuss with all of you about what could be the result of the vessel prep we did till now, and what could be the best therapy for the patient. So let's go ahead with the check. This is the Enzo control. Not bad. Still recoiling in the pop. Still dissection. Well, dissection, and we have a collateral in the P1, P2 segment. This homogeneous vessel and some recoiling in the ostium of anterior tibia. So, your opinion, guys?
First, congratulations, because you have done a very nice intervention so far. So the only one question is now to stent or not to stent. In my opinion, I wouldn't stent it. I would just DCB the lesion. But I will ask our panelists also.
Dr. Rujas had just in a few minutes a very good presentation about FFR and functional judgment of the result. So would you do FFR in this case?
No, in this case they have transpedal access, so I would measure now the transpedal pressure.
No, they don't have.
No, they punctured in the beginning.
It's out.
Yeah, but we'll remove.
But it's okay also, it's distal. So you can measure the distal pressure. If the pressure is up to 100, then you will have a good wound healing. So it's that is a very good direct assessment of the. Do you have the distal access? I think, or you removed it?
No, we don't have.
You don't have it. Then okay. Then now I.
Acquisition. No, we don't have the invasive pressure here.
Only DCB now.
So,
flow is excellent. You have a good feeling of the plantar arch. Very nice result. Italian masterpiece.
nobody of you asked for a second projection, but since I'm mostly a radiologist, I will do a second projection to see how is this lumen, if we have recoiling or not. Invite all of you to think that the crossing was subintimal after failure and perforation in a heavily calcified artery. So with this result, I, more than before, start to think about stent.
Absolutely. We have the recoil at the...
As a fully dissected artery, look at the inflow. There is recoiling. Fully agree with the physiological measurement with the functional images and measurements. But here, I think if we pass IVUS, most probably we finish with the stent, because it's
100%.
100%. Yeah,
This is a very good
because it's fully dissected the
I'm using
artery,
more and more
because
for
the crossing
SFA.
is clearly
In this case,
subintimal in this calcified artery.
distal
So
popliteal free segment
It's
is
changed. The second image
subintimal,
changed
so you
in
will
some
see
way
the
your
subintimal
decision,
plane.
guys, or
Then
still
I would not put the
you
stent
suggest
because it will close it.
DCB,
If there
which
is
could be another
subintimal
option. I
space
mean,
there, I would just cut
3
cut
minute,
balloon
5
it,
minute dilatation
and I
with
would
the
do then
DCB
the
could be
DCB,
another
but,
option.
In the
and
proximal part, you
finally
can
see.
stent it because it's at the beginning is ugly looking a little. But
Well, from the other hand, there is a big lumen of the distal popliteal. It's no doubt subintimal recanalization. So it's dissected artery, 100%. But there is only one vessel runoff, and it goes with very brisk flow. So probably it's better not to stent, or just wait about 10 minutes and see how is it without the wire. If there is recoil and something different in some minutes, then
There is not
So
only
probably
one
need a stent.
vessel. We only have one vessel connected. But as from the beginning, there was 3, and you will see we have peroneal and posterior tibial coming from collaterals, like
Ivo Petrov speaking. What do you think about
You can see now
excellent distal flow,
peroneal
definitely,
arriving
but probably at the place
later,
of the,
more
of
later,
the residual stenosis,
even
probably
something
it's
of
the exit of the
posterior tibial.
dissection
So,
or
yeah.
what is the situation
We
inside the
clearly
vessel. It
improve
would
the
be nice to
perfusion
have
for the
IVUS
foot.
imaging in order to decide what to
In
do.
a claudican patient or rest pain patient, I think the discussion should be more and more open because you have time. In CLI patient with this result, I tend to put stent, honestly. The result of many trials, even the super sub 1 or 2 trials with supera stent in subintimal and calcified arteries suggest big benefit of a stenting after this type of therapy. But yeah, any patient is up to himself, so the discussion is fully open. I don't know.
I think the problem is the anterior tibial artery or the ostium, because if you put there a stent, especially if you put a super stent, 100% it will be closed in 1 month. So when I've done more than 300 superas, and if you put in the popliteal 2-3 is okay, but if you protrude the stent in the anterior tibial or the tibiofibular trunk, it will close. So if you put just proximal a little,
this
then,
affirmation,
and
you are
DCB,
affirming
that would
that
be a
the
good
stent is
strategy
going to
also.
be closed
A
in 1
hybrid
month.
strategy,
You
it
have
means.
any literature you can show us about that? Because honestly, I don't agree with you in this. So you have some data that you can tell us about this supera in the proximal tibials? Because we have many cases like this in which we focus to stand from healthy to healthy segment, and we saw excellent patency at 2 years.
Thank you very much. With the session.
Okay,
The second
I
presentation.
suggest we continue with our work and we show you the last image after that. So you can go on with the
Okay,
presentation.
thank you very much. We'll continue with the session now, and we'll come back in 10 minutes to see
Okay.
the results, okay?
Supera 120 distally. You can see.
Can you hear us?
We hear you, but we can see you're very
You can see the
handsome,
images.
but can we see the images, please?
We would like to show you the images, yeah.
Okay, believe us,
That's
believe
it.
us.
No, that's it. They are seeing now. So the checks we did before to proceed with the stent, we show you. Finally, 5.5, 120, supera stent starting in the ostium of anterior tibial. Well deployed stent, no elongation, no compression. First check, fantastic ostium of anterior tibial, still proximal dissection. So we decide to proceed with the 680. Yeah, 680 again to finish the stenting from healthy to healthy area. Afterwards, we decide just to post-dilate a bit the stent the stent overlap between both stents. We work with the 6 mm balloon, so we post-dilate a bit distal and also proximal. And this was the first check after stenting with super good flow, no more slow flow, no more any dissection, and excellent inflow into the anterior tibial. So afterwards we did this check also of the anterior tibial with very good flow, and the last check in the foot with excellent flow and perfusion for the foot. And to try to open a bit more the discussion, we decided to go with this flexion knee, 90 degrees flexion knee, to see the performance of the supera stent in the popliteal area, how the stent adapt to the curves, where the curves are, and how the stent adapt to the ostium of anterior tibial. This is the place in which popliteal artery or anterior tibial pass through the interbone membrane, and always the artery can be collapsed in flexion. So you can see that with supera in this part we have excellent performance without any compression, any problem. And after this, we decide to go with the 6 French angioseal and the ultrasound to close the access, and that's it. So if you have any doubt or question or something that you want to discuss, we are here to finish the discussion with you.
Thank you, amazing case. What do you think about
Do you want it?
orbital devices?
Mariano, you did great job. Thank you very much for this case and for coming and joining us for the endovascular course. As always, you are the real master.